I wanted to just take a couple of minutes to introduce Ian. I know that we work diligently in recruiting Ian, who came in to interview several times. We were, very lucky that we were able to recruit him after having done his MD at Harvard MIT program. Then he did his neurosurgery at USC, then went on to Columbia to do an enfolded fellowship. First did an enfolded fellowship at USC in complex spine surgery. I heard about him from all the colleagues, from USC. And then he went on to do a fellowship at the Columbia University at the Spine Hospital in New York City. A tremendous amount of awards, including the Howard Hughes Medical Research Fellowship when he was at the Harvard MIT program. And you can actually see the tremendous accomplishments that he had over time. High index, H index, as you know, we continue to track that. You can actually see his impact on the literature, and a tremendous amount of publications with a lot of depth and a lot of opportunity, of course, for growth in a fertile ground, which he continues. He's been very, very active in this issue of artificial intelligence and using kind of new robotics and new inventions in neurosurgery. And he came out with this title. So I thought that I put this, The Rise of the Machines, and I realized it sounded familiar. And then I did a Google search, and it was the title of the Terminator 3. So Ian, without any further, we're very, very excited. I'm going to stop sharing this right here. We're excited to have you here. Thank you for joining us. And, I gave you extra 4 minutes. I know, but whatever we can do, if you don't finish, we'll take, step 2 in your talk. All right. Take it away, Ian.
Sounds good. 1 second. Let's get this started here. Can you hear me?
We can hear you well, and we can see part of it. Maybe you just got to put it in the presentation mode. Yeah. We're like seeing part of it or something.
How about that?
Yeah, there you go. Now we see it well.
Perfect. So good morning, everyone. I'll be talking about a topic that's of considerable interest to spine surgery and healthcare as a whole. And that's really the rise of machine learning as a subset of artificial intelligence in spine surgery. I have no financial disclosures. If it isn't already obvious, the title of my talk is a direct play on the Terminator movie franchise. And in the third installation of the series, Skynet sends a Terminator back in time to ensure the rise of the machines, which is where the title of the movie comes from. I like this clip because one of the key features of the Terminator machines is their ability to take on human form. And while they may not be taking on our physical form, in real life, machine learning algorithms are studying us in different ways on a daily basis to predict our behaviors and our daily patterns. Think of AI as the ability to engineer cognitive function. It dates back to the 1950s when it was first founded as an academic discipline, and advances in computational power, as well as the development of machine learning as a subset of AI, basically has advanced our capabilities. Simply put, machine learning is the ability of a computer to perform tasks without explicit instructions and relying on patterns. Machine learning algorithms have to be trained on vast amounts of data, and the more data typically, the better they get. AI has really ushered in a world of predictive analytics. You decide to drive to the airport, and immediately available to you are several routes along with the ETA for each, and more often than not, the times are spot on because they're factoring in traffic patterns, weather patterns. Or you land at the airport and you request an Uber. How far away is the car? How long will it take for you to get home? Again, those estimates are typically very on point. Or you order pizza on a Friday night in New York City along with everyone else. How far away is the delivery guy? You turn on your television to watch Netflix, and it's already studied your preferences and it makes suggestions for what to watch. This is the world of predictive analytics. There's considerable interest in artificial intelligence in all areas of healthcare, and cost reduction measures is of considerable interest because spine care is costly. By 2025, the total healthcare expenditure is projected to be about $5.3 trillion. That's 20% of GDP. And the annual spine expenditure alone is $110 billion, which is 2% of that. So part of the high cost comes from the incredible variability in treatment patterns. Take the scenario of a 45-year-old gentleman who comes in with chronic low back pain and has evidence of a degenerative lumbar spondylolisthesis. Well, what are your options? Laminectomy, laminophoraminotomy, laminectomy with inside to posterior lateral fusion, laminectomy with instrumented posterior fusion, a TLIF, an ALIF, a lateral lumbar interbody fusion. Is there an optimal plan? I think it's impossible for clinicians to factor in all the discrete data points that would go into what that optimal decision is. There's demographic factors, underlying comorbidities, psychosocial factors. And so this is where I think artificial intelligence comes in and has a promise to change the treatment decisions and the way we manage disease processes going forward. I think AI has impacted virtually all areas of patient management, and spine surgery is no different. It's really impossible to cover them all in this talk, so we'll focus mostly on surgical planning. But I think as the wait list grows for patients to get in to see physicians, including spine providers, a key question is going to be, how do we optimally triage those patients who need to get to us? And I think there's a particular area of interest in this for us here at the Mayo, and we have some collaborations that are ongoing for this. AI is also important for surgical outcomes and research. There's a wealth of information out there, and I'll touch on those briefly. So one of the problems with current deformity classification schemes in spine surgery is that they only look at radiographic outcomes, and they don't factor in demographic factors and clinical variables like age, the frailty index, body mass index, or whether or not patients have had prior surgery. And those are all factors that we know influence surgical outcomes. So how do we look at the data more holistically? I think AI gives us a new way to look at patient data. This is a work by Ames et al. In which they used unsupervised AI-based hierarchical clustering to segregate patient patterns based on hundreds of data inputs to come up with a new deformity classification scheme. They created these dendrograms based on clustering of patient parameters and the one on the left, and surgical parameters and the one on the right. Now, patients with similar characteristics are clustered closer to the center of the defined clusters, and those with greater similarity to the other defined cohorts are closer to the border. On the left, when you look at the patient data alone, AI basically sorts patients into three intuitive cohorts. The blue ones are patients who are younger and have primarily coronal deformity. The yellow ones on the left are patients who are older and are undergoing revision surgery. Patients in gray are older patients who are undergoing surgery for the first time. And on the right, the patterns are segregated based on the treatment patterns. So patients who have had 3-column osteotomy are in blue. Those who have had inner body fusion are in gray. Those in red are patients who've had Ponti osteotomies. And those in yellow have had no osteotomies or any interbody fusions. It's a new way to look at the data. And in this way, AI is really unearthing clinically relevant information buried within vast amounts of data in a form that previously hasn't been done. So what is this good for? Well, when the authors crossed the surgical clusters with the patient-defined clusters, they were able to come up with these risk-benefit graded analyses where treatment patterns can be chosen based on optimizing benefit and minimizing risk. So as an example, patients who were in the older revision cluster undergoing 3-column osteotomy, highlighted here with this red circle, those were patients who basically had higher perioperative complications. But if you look at their patient-reported outcomes, they were the ones who were most likely to benefit from the treatment because they had higher ODI scores, or sorry, higher improvement in their outcome measures. So from a diagnostic standpoint, I think there's considerable interest for AI, and this is really one of the first areas where attempts were made. So when expert radiologists read any MRI, there is high inter-reader variability. Machine learning algorithms have been developed to facilitate computer-aided interpretation of spinal imaging. And the models have gotten better and better with time, and now they exhibit near human performance. This was a group from MGH that developed a convoluted neural network to diagnose central and neuroforaminal stenosis on both axial and sagittal slices of the MRI. They trained this machine learning algorithm on 22,796 disk space levels from a total of 4,075 patients. And the diagnostic accuracy for canal stenosis was 80%. The diagnostic accuracy for foraminal stenosis was 78%. So clearly the algorithms are improving and they're getting better and better with time. Other groups have applied machine learning to diagnosing specific conditions like cervical myelopathy, and are able to predict its severity based on imaging alone. So this was a pilot study with a small sample size of only 28 patients, but it was successful in diagnosing myelopathy 88% of the time. More importantly, they were able to predict the modified JOA score based on computer automated averaging of spinal cord volumes. So this is obviously one disease process, but much of the diagnosis in medicine hinges on imaging or interpretation. And I think AI will really revolutionize diagnostic paradigms going forward. I think we'll shift now to the primary focus of the talk, which is how AI has really impacted surgical planning. I think it'd be impossible to give this talk without mentioning navigation or robotics. I think neuronavigation is really becoming the standard of care for the reasons listed on this slide. You know, complex anatomy is made easy, it's efficient, it's reproducible, and over the course of long surgeries where humans fatigue, robots do not. So I think on that basis, the reproducibility is something that is just really important. There is improved pedicle fit fill, which means stronger constructs. It optimizes screw alignment for routing purposes. It reduces surgeon frustration and OR stress. And I think it increases patient safety. So I trained with Lenky, and he was old school. He typically made 3D models for all his complex cases, and he took them home at night and he studied them, all the individual nuances of his patients before surgery. And over the course of his career, he's amassed quite a number of models, as you can see on his windowsill. I think eventually they'll block out the sunlight. But he's a wizard of the spine, and he would bring these models into surgery, and he'd place them in a sterile bag, and he'd look at them throughout the case. And I think for him, it works. But there's a new, more modern way of doing this, which is real-time intraoperative visualization without the need for a physical model. And so how does navigation and robotics help us? Well, we can plan our screws before surgery, and it simplifies challenging anatomy. So if we take a look at this revision case with a Harrington rod, for example, I think it'd be really difficult to place screws without removing the Harrington rod. And even then, the fusion mass would obscure the standard anatomic landmarks that you'd use for screw placement. So not only can we optimize screw placement with our planning and navigation, but you can ultimately make routing easier. You take a look at where these the highlighted portions are, the T12 screw. I think both these screws on the axial image are fine, but one is just more optimally aligned for planning. And so I think you can make your lives easier, because the goal ultimately is to put that rod on. It's not just getting the screws in. There's definitely a learning curve to incorporating robotics. There's no doubt about that. But I think once it's been mastered, it contributes to efficiency and improved workflow. So this is a video clip. A single screw goes down in 46 seconds once the registration has been completed. So it's faster, it's safer, and it really streamlines operative workflow. So I think real-time imaging facilitated by AI algorithms will only continue to advance, and incorporation of virtual reality and new heads-up displays will only bolster this going forward. And I think it's exciting times ahead as far as navigation and incorporation of virtual reality. There's no doubt that the tools that we have grown, and I think so too has our knowledge. If you go back to the early 90s, our overall understanding of spinal alignment boiled down to the cone of economy that was developed by Debussy. In simple terms, it says that a human stands with a certain zone of balance, which is an inverted cone in which the torso remains a certain distance from the pelvis, and outside of that cone, energy expenditure goes up considerably. In 2013, the SRS Schwab classification system gave us defined surgical targets based on health-related quality of life measures. So that meant from a sagittal alignment standpoint, you wanted your sagittal vertical axis to be less than 4 centimeters. For pelvic tilt, we wanted under 20 degrees. And that any pelvic incidence, lumbar lordosis mismatch, should ideally be less than 10 degrees as well. But since then, our understanding has grown even further. Yilgor et al. In 2017 came up with this concept of the global alignment and proportion score concept, which you can see here factors in more than just a PI-LL mismatch less than 10 degrees. There are a number of other factors that have to be considered: the spatial orientation of the pelvis, the distribution of the lumbar lordosis or the lordosis distribution index seen in the schematic on the left. In other words, it doesn't just matter that you have to get lordosis, but where you place the lordosis matters. And in an optimal setting, you want 50 to 80% of your lordosis to be at the L4 to S1 level. Well, why is this important? Well, because if you undercorrect or overcorrect the spine, both of those have implications because there's an increased risk for mechanical complications, whether rod breakage or proximal junctional kyphosis or distal junctional kyphosis. So this was a series of patients where they basically found that hyperlordosis increases the odds of mechanical complication by 23-fold in comparison to patients who were perfectly aligned. And severe hyperlordosis caused a 31-fold greater increase of a mechanical complication to patients that were optimally aligned. So how are we doing in terms of achieving correction from a deformity standpoint? This was a multi-center prospective study of deformity patients using the ISSG data. Patients were evaluated at baseline and then 1 year after surgery. And what they found was that only 23% of patients with a deformity had complete radiographic correction, 23%. As far as sagittal deformity, which is probably the most prominent that's been associated with health-related quality of life measures, only 50% of patients were corrected. Of all the spinopelvic parameters, pelvic tilt was the least likely to be corrected, and that was only done in about a quarter of patients. So it's not just a deformity thing. If you look at 1 or 2 level lumbar fusions, malalignment is also common. This is important because if we think of proximal junctional kyphosis and proximal junctional failure in deformity, then the corollary to that in shorter and smaller surgeries is adjacent segment disease and adjacent segment failure. This is a multi-center retrospective review of 578 patients, and malaligned was defined as PI-LL mismatch of more than 10 degrees. And what they showed was that 6.6% of patients who had a 1 or 2 level fusion went from normal alignment to malalignment. And patients who were malaligned before and after surgery, meaning they weren't corrected, that was somewhere in the order of 21 patients. So I think obviously it's really challenging to get the correction that we want, but how do we know if we've corrected enough intraoperatively? I think, we know the spine is not a static structure. There are compensatory changes that ensue. So how do we account for these compensatory changes? And even if we do an operation in the lower lumbar spine, we know that there are compensatory thoracic changes that occur, and these can be difficult to predict. And I think this is where predictive analytics has really changed the game because it allows for personalized spine surgery. Medtronic's acquisition of Medicrea in 2020 really, I think, increased their dominance as a company that's leveraging AI for predictive analytics and surgical planning. The Unity platform relies on machine learning to predictively model surgical output, and this is based on a data bank of, I think, 8,000 prior surgeries. It's an iterative process in which every surgery that's performed gets fed back into the database so that the platform, in theory, learns with each case. It's a 7-step process, which you can see here from their brochure, and we'll go through each of the steps in an example in a case. So step 1, images are submitted for analysis through their application, which you can download on your phone. Spinal pelvic parameters are rapidly determined, and you can formulate a plan in terms of how much correction is required. In step 2, Surgical strategies can then be developed based on surgeon preference and using their algorithm, taking into account previous cases. So what does this look like? Well, here's a case I was involved with in which preoperative and postoperative, preoperative frontal and sagittal x-rays are submitted on the Unity platform, and it quickly determines spinal pelvic parameters such as pelvic tilt, pelvic incidence, sacral slope, really all the measurements that will be relevant for clinical decision making. And I think anyone who's measured all of these knows how tedious a process this can be. So based on these measurements, a plan can then be formulated, and you can simulate various surgical approaches with osteotomy planning, cage planning, and you can even plan the rod. And this can all be modified, obviously, based on surgeon preference for surgical approach. Once you finalize your plan, the implant can then be personalized, and the rods manufactured specific to the patient. Patient-specific rods were approved by the FDA in 2014 and have been in use since. These rods are then synthesized in a very specific shape, specific to the patient, and they can then be shipped in sterile packaging for use in the OR. The surgery is executed. Once the surgery is done, post-operative x-rays are submitted by the same platform, and the correction is measured and analyzed, and this output is then fed back into the algorithm in step 6. So the machine learns from each case and gains insight about all the compensatory maneuvers that otherwise would have a detrimental impact on outcome that as an individual surgeon, you're probably not taking into account. And so with every surgery, the predictive modeling improves, and currently there are over 8,000 cases in that data bank. So here's a case illustration from one I was involved with in fellowship, which shows the tremendous utility for this platform. So this is a 52-year-old female with restrictive lung disease, osteoporosis, monoclonal gammopathy of uncertain significance, and a progressive chin on chest deformity. She complains of gradual loss of ability to maintain horizontal gaze, and she's only able to ambulate short distances, but is otherwise wheelchair bound. Standing films show her profound cervicothoracic kyphosis with her inability to maintain horizontal gaze. And her kyphosis is such that her head is really outside the frame of the x-rays, which you can appreciate on that sagittal x-ray. She has profound fixed sagittal imbalance. Her sagittal vertical axis is 23 centimeters. Her PI-LL mismatch is 27 degrees, and her thoracic kyphosis is on the order of 83 degrees. She has some improvement in her kyphosis between standing and supine films, supine being on the right here, but it's not substantial, suggesting that this is a rigid deformity. And again, in her standing versus prone films, you can see that this is quite rigid, and the 3D CT scan shows the extent of the pathology. There's really ankylosis of virtually all the vertebra, including the posterior elements, spinous processes, and at some levels, the individual ribs. Select sagittal cuts again show this. The posterior spinous processes are all fused together, and as are the vertebrae, which you can appreciate on the coronal shots there. An MRI of the cervical spine shows severe central stenosis at the C3-4 level and moderate stenosis at C4-5 with severe neuroforaminal involvement on the left. There's no significant central stenosis throughout the thoracic or lumbar spine. So from a treatment plan standpoint, I think traction is certainly helpful for a case like this in the context of her chin on chest deformity, but ultimately this is going to be a two-stage operation. I think in stage 1, she'll likely need C2 to ilium with laminectomies at C3 through 6 and PCOs, which will be difficult given that the entire spine is ankylosed. And stage 2 will be pedicle subtraction osteotomy with deformity correction. So here we are with traction. She's got some improvement with 29 pounds on her halo. You can see the head is now at least somewhat within the sagittal shot. And we execute a stage 1 surgery, C2 to ilium, with some improvement in her malalignment. Her SVA goes from 26 centimeters in the initial measurement to 13 centimeters here. Her thoracic kyphosis goes from 83 degrees down to 67, but there's still a ways to go. So this is where the Unity Medtronic predictive modeling system that's based on artificial intelligence is really helpful. So we submit our pre-op x-rays again, and we can simulate multiple plans based on that. Here we have simulated plan A, which is a pedicle subtraction osteotomy at L3, versus plan B, a T12 pedicle subtraction osteotomy. We elected to go with an L3 PSO, and the plan is submitted. The rod is manufactured, which you can see here on the right. And I think this is a picture of the actual rod intraoperatively, and I think it'd be really difficult to bend that rod to this precise shape, especially a 6-sol cobalt chrome rod. And so to have this come manufactured, notch free, is really great. We talked about how do we know if enough is enough. So here we've done our extended PSO intraoperatively. You can see the L2 and the L4 screws are kissing, and the rod falls perfectly into place, and it acts as a measure or an intraoperative gauge for how much correction is enough. And here, the actual surgical plan on the left perfectly overlays with the intraoperative X-ray, and again answers the question of really how do you know if you've achieved enough correction from an intraoperative standpoint. So here are the sequence of X-rays between standing, AP, and lateral. Between stage 1 and stage 2, there's considerable correction of the malalignment, and if we measure that, our SVA goes from 23 initially down to 13, now down to 5 centimeters after stage 2, and the PI-LL mismatch is normalizes and is now less than 8 degrees. And you can appreciate the full progression of her correction from pre-op to post-op on these scans, and now she can look forward. Her chin-on-chest malalignment has been corrected. So the case is done, but we're not done. There's data collection, and the machine has to learn from that case. So here's a deviation form or a feedback form, which contributes to the algorithm learning. So did you deviate from the plan? What cages did you use? What levels? Did you do the osteotomies you said you would do? What levels did you do, and were they different? Were additional screws placed or was your UIV or LIV different? Did you end up having to bed the rod that was prefabricated? This is all part of the iterative process of machine learning, and that gets fed back into step 5 here, and the model continues to learn and improves. So I think in many ways, rodding is the decisive portion of a stage where correction happens, and it can be the most difficult portion of the case. Here's a video of us manually bending a rod with a French bender in fellowship. And I think rodding is an art form, but there's a risk of overbending or underbending the rod. And we know that that has dire consequences from some of the data that I showed earlier, which says that essentially you can have increased rates of mechanical complications, which means more revision surgeries, which means we're increasing the cost of healthcare. So I think there's tremendous utility for predictive analytics from this standpoint, because it serves as a gauge for intraoperative correction. Personalized rods save time, and it allows you to lock the patient into optimal alignment. The rods are also notch-free, and therefore they have a higher fatigue stress. And I think ultimately it decreases surgeon stress and frustration in terms of bending these rods. And I think ultimately it contributes to improved patient outcomes. I think some of the early data that I'll show here indicates that that is the case. If we look at the ISSG rod fracture data, the deformity cases, which here is defined as cases where 5 or more levels were instrumented, there were 200 cases with a minimum of 1-year follow-up, and there were 18 fractures. That's a 9% rate for deformity cases. If you look at pedicle subtraction osteotomy cases, or in particular, the fracture rate is significantly higher at 22%. And if you only look at non-PSO cases, it's 4.7%. There are a couple other papers like Hamilton et al. Using ISSG data, which says that the rates are for total overall deformity cases can be as high as 15%. But if we do the comparison using the previous data, and you look at the same criteria with the Unity rod with the personalized rods, what you'll notice is that with the Unity rods, the fracture rate for deformity cases is only 2.2% in comparison to 9%. And if you look at PSO cases in particular, the fracture rate goes down from 22% to 4.7%. So I think these are early results, but it shows that there's certainly a decrease in the rod fracture data and decrease in the revision rates as well. There are also reports which show that there's overall improvement in radiographic correction, but these studies are small scale, and I'm not aware of any large scale publications in peer-reviewed journal looking at the Unity rods in particular. It's not just rods. There's an emergence of 3D printing, and this really allows us to personalize spine implants. The Unity system at Medtronic allows you to do patient-specific corpectomy cages as well. This is an article in a prospective clinical study of 6 patients who were implanted with patient-specific corpectomy cages for myelopathy. And they measured the Cobb angles and the anterior and posterior defect heights, which remained stable after 2 years, which means decreased rate of subsidence. Now, it's only a small sample, and larger studies are needed to be done to validate this. But I think it's really an exciting time, because anyone who's done these cases knows how frustrating it is to try to get those end plates perfectly parallel. And if you don't, then obviously the rates of subsidence go up considerably. I would say that the impact of AI on spine surgery has been tremendous, and it's really led to an emergence of predictive analytics and a world of personalized spine surgery. It streamlines the operative workflow, which means less surgeon stress as far as rodding and screw placement. There's a shorter operative time, increased patient safety, improved patient outcomes. And I think with decreased rod fracture rates and optimized alignment radiographically, that's going to contribute to a decrease in revision, need for revision surgeries, and ultimately a reduction in healthcare costs. I think what I'll say in ending is that machine learning and AI is certainly on the rise, and I think these are machines that are certainly here to stay. And with that, I'll take any questions.
Thank you, Dr. Buchanan. Wonderful. I think that we have a few questions from some of our spine colleagues right there. I think Olu already raised his hand. Olu, take it away, and then Dr. Aboriyama. We'll go in that order. Take it away, Olu, please.
Yeah, that was great. Yeah, Dr. Buchanan, I mean, that was a great talk. And I mean, it really highlights a lot of the things that many spine surgeons are really interested in, and a lot of the trends we're seeing. I mean, I was especially interested in some of the things you were showing about the planning for those corrective surgeries. And because I mean, that's a question I always have when I'm doing this case with you guys is, how do you know when to stop? How do you know if your correction is enough or too much? How do you know if the shoulders are going to be malaligned afterwards? And some of those things are going to be great to kind of predict that. But with some of those newer technologies and instrumentation and the 3D printing, for example, that stuff is expensive. And my question is, what is the current trend that you see with reimbursement for some of these things? Because I mean, you can do them, you can get them, but how often are you going to be able to get them reimbursed by insurance? And where do you see that trend heading? And also, what things can we do in the future to kind of be sure that these things are going to be reimbursed, so we can continue to use them on on a wider scale?
Yeah, so I mean, I think certainly cost is always a question that comes into play when we start coming up with new technologies. But the reality of it is, a lot of patients were fused into flat back or have been fused into flat back. And a lot of patients ultimately go on to have proximal junctional kyphosis and failure. And those patients ultimately have to undergo a revision procedure. And the costs of a revision spine surgery are substantially higher than the cost of that index surgery. So if you start to factor in the need for a revision if someone's fused into poor alignment, ultimately, if you do the surgery right the first way with predictive analytics, I think ultimately the cost may end up being cheaper. But it's a patient safety issue, right? Revision surgeries have higher rates of complication. And again, if you optimize your correction the first time and minimize the chances of ever having to go back, I think you save your costs in the long run. As far as reimbursement from the standpoint of insurance companies, I think, the costs for these and a lot of these implants are certainly high, but as we've all seen, the cost of 3D printing has dramatically decreased over time. And I think the cost of a lot of these technologies will continue to decrease as other companies develop their own platforms and they start to compete with each other. So I think much like neuronavigation, which is now becoming the standard of care, I think there's no doubt that it makes it a safer placement of screws for patient. There's no doubt that it makes for stronger constructs because you can maximize pedicle fit and fill. You can decrease the chances that your screws are going to pull out, and you can optimize the correction that you get overall. So I think the sticker shock of a lot of these technologies is really high on the front end, But I think we ultimately have to think about what the revision costs are going to be if we don't do a good job to begin with. And I think these technologies are really helping us hit a home run the first time around.
Yeah, that's good. Thank you. Yeah, so hopefully, I'm sure with time, publications and things like that can prove these kind of things to the, insurance companies and everyone else.
Even my puppies got excited, Dr. Buchanan. We'll pivot to Dr. Aboriyama because they are looking at your pictures right here. Go ahead,
Great
Kinsley.
talk. Great talk, Ian. I had similar questions about cost as well, but the other thing that I wanted to ask about was more or less, back, when I was a resident, I remember SurgiMap being used frequently. And so some of those data that you pointed out with fracture rate, how much of that is just simply due to people not accurately correcting versus what the rod itself is doing?
Yeah, I mean that's a great question, right? A lot of you're talking about the ISSG data, right?
Correct.
Yeah, I think one of the challenges is, especially with a platform like this, is it's relying on especially the Unity platform hub. It's relying on multiple surgeons, and we all know there's an incredible heterogeneity between the surgeons, and so how do you really know someone's doing a good job at correcting? I think your chances of correction are better with Unity, at least more uniform compared to ISSG, where that's the exact question you're asking. How do you know you've gotten the correction? In actuality, you don't. I think that all you can look at are the rates of malalignment, which are some of the data I showed, and we know that a significant number of patients are being undercorrected. And the only thing we have as a uniform comparison is take the same number of levels and relatively the same population with patients who've had patient-specific rods and sort of do a side-to-side comparison. I don't think it's perfect, but I think it's the closest that we get. And it shows with the Unity that at least, or with the Medtronic AI platform, that at least the correction appears to be better. That remains to be proven with larger scale studies. But I think you point out a great question. How do we know that we're comparing apples to apples and apples to oranges? And we don't know. All we know is we assume the surgeon did the best job that they could with the ISSG data. And that's the closest that we can get.
Hey, Ian, I had a question. Can you hear me?
Yeah, go ahead.
I know Olu brought up cost, but do you know what the actual cost is of a pre-bent rod for the patient that you order as compared to a regular rod?
Yeah, I don't know the exact cost of that, no.
And also with the AI, does the Medtronic Mazor robot have AI yet where it automatically plans your screws, or does that still have to be manually done?
No, typically manually, it'll give suggestions for screw placements, but we manually plan optimally where we want the screws to be ultimately for routing purposes.
Okay, and then you see the last question I had was,
but I think when you place those screws, obviously it gives you sky potential and it takes into account certain iterations and it helps you optimize the screw. But I think ultimately you decide in your final trajectory and plan where you want those screws to be.
And the last thing I was going to bring up is, do you see this ultimately taking over spine surgery, where the spine surgeon's not even operating anymore, or not?
No, I don't think so. The reality of it, these tools are all adjuncts for the work that we do. The case I showed is a classic example. You can plan all you want. The osteotomies, you get in there and it's a real life scenario where all the spinal processes are fused and then the ribs are fused together. The vertebrae are all fused. It's difficult to do a simple SPO and get the degrees of correction and do an additive fashion of how much correction you actually need. I think ultimately you're going to need a surgeon that's going to dictate what's safe and what the ultimate correction is going to be. These are all tools that are, they're not going to be a replacement for the surgeon. They're just going to help us do it safer, better, more efficient, and in a cheaper fashion. So I think ultimately, we're not going to be replaced by these machines, but I think, like this picture here, we'll stand side by side in the operating.
Beautiful, thank you. Gaetano next, and then Dr. Aboriyama had his hand raised again. Go ahead, Gaetano.
Hey, sir, great talk. I have a question kind of related to Dr. Nandmeyer's comments. So you showed beautifully how AI can be used for predictive analytics and surgical planning, but is there any current integration with the robotics, with the Mazor or the Medtronic, and also in the future, do you see any integration for the robot, not just helping in like pedicle screw placement, but doing more assisting with the surgeon through the use of AI and machine learning? Thank you.
Yeah, I mean, I think that's a great question. Look, ultimately, the AI is allowing us to essentially garner more information from images than we can typically do just by looking at it. I think ultimately in the future, eventually you'll be able to get an MRI, and that MRI will tell you based on bone density. It'll tell you, is the patient osteoporotic? It'll factor in, what the optimal alignment will be for screws. I think eventually there will be an overlay to this into the operating room using MRI scans, where you'll be able to visualize the anatomy and be able to visualize the nerve in real fashion and decompress it appropriately. I think the technology is getting better and better, and as it is, they're sort of standalone entities that are useful from an imaging standpoint or from a screw placement standpoint. But I think ultimately the platform will become integrated into virtual reality, where you'll see imaging in real time, and the robots will help facilitate screw placement. It will help make optimal decisions for where implants should be or what the implant should be. And it will become more of an active role of the robot as opposed to something where I want it to show me where the optimal place is to place a screw. So, I mean, I think a lot of this is in the beginning stages. And I think it's an incredible time, because what we will ultimately be able to accomplish is more of a participatory role with a lot of these equipment, rather than something that's an assistive tool.
I see that Dr. Boriyama, I think he lowered his hand. One last question, Ian, as I look at this and I saw the video that you show where you fix all the way from the pelvis up to the cervical spine. Do you think that in the future, with all this information you're gathering about patients, following the patients over time, that you'll be able to combine surgeries that are less invasive, where you get to fix one, area of the spine, minimally invasive, and then use some form of exoskeleton to stimulate muscle strengthening, correction over time, and that way prevent these extraordinarily large surgeries? Is that something that is already being thought of, or what are your thoughts about that?
I mean, I think the world is our oyster. I think anything is possible. I mean, the case I showed was a sort of a very unusual example of someone who had a very bad problem where, she's unable to look forward. And I think the treatment in that case is really only a seat to the pelvis fixation. But I think the goal is, with AI, you're asking, are we going to be using exoskeletons? It's entirely possible. I'm not sure. But I think as it speaks now, these technologies are helping us optimize what the best treatment plan is for patients. And I think when we plan surgeries, we take into account factors that are based on our own experience, what's worked for us in the past. Now, is that the right thing for a specific patient? It may not be, because I think the number of variables we can factor in is really finite, whereas the number of variables AI can factor in as far as patient demographics and clinical factors and psychosocial factors is really unlimited. So it's going to revolutionize the way we look at treatment paradigms, because it helps us factor in imaging with all the patient individual demographics and variables, and we'll be able to look at patients holistically, as opposed to, this is a problem that I fixed in the past and this is the way it's worked, and here's a nail, here's a hammer, and let's use that hammer with the nail. I think it really helps us treat the patient, and it's really leading to an era of personalized surgery that's more than just a picture and how do we fix this picture.
Beautiful, thank you. Well, beautiful talk. Great, we're excited about the new technologies, the new innovations that will come out of these new intellectual property. I know that you're working on some of these things, and also the way in which you're going to be using artificial intelligence isn't even to be able to chaperone patients as they're coming to clinic, which is something that is also has been a challenge for many practices, not just ours. It's how do you predict which patients need to be seen sooner rather than later? I know you're working with that with Michael and our team. So we're very excited to partner with you on that endeavor. Thank you, Dr. Buchanan. And thanks everybody. Welcome to the new year. Next week, remember, we have Sonia Mejia from Mexico City joining us, and we're really, really excited. As a visiting professor, I encourage our faculty to meet with her. I encourage our residents to meet with her. That's how you build international practices, not just practices that are here in the United States, but this is how you ended up getting a lot of referrals from colleagues around the world. So welcome everybody to the new year, and stay safe, please. All right. Thank you, Ian. Take care. Bye-bye.